Good evening, everybody. We might get started. Can everybody hear me? Yes? Good. Okay. I'd like to welcome everyone tonight to our education session, How to Influence Patients to Change Their Behaviour, Cardiovascular Disease and Lifestyle Medicine in Practice. So, firstly, I'd just like to acknowledge the traditional custodians of the land on which we live and work and of the many different nations across the wider Brisbane South region. We pay our respects to the elders, past, present and emerging, as the holders of the memories, the traditions, the culture and the spiritual well-being of the Aboriginal and Torres Strait Islander peoples across the nation. We acknowledge any sorry business that may be affecting the communities as a whole. In the spirit of reconciliation, partnership and mutual respect, we will continue to work together with Aboriginal and Torres Strait Islander peoples to shape a health system which responds to the needs and aspirations of the community. Just a little bit of housekeeping before we get started with the presentations. If anyone hasn't found the toilets yet, you go out of the door that you came in, turn to your right and they're on the left. Fire exits, there's emergency exits there and out of the door that you also came through. If you wouldn't mind putting your phones on silent, that would be great. We will send out an evaluation tomorrow or in the next few days, and we do appreciate your feedback. So it'd be great if you could complete those for us. And we do take your feedback into consideration when planning future events. COVID safety, we have hand gel spaced out. As I said, there's toilets so that you can wash your hands. If anyone hasn't signed in, use the QR code to sign in, please let us know. And on your way out, there is a checkout QR code, if you wouldn't mind on your way out just using that as well. There are a number of resources which you've probably, I hope, had time to look at, but you can have a look at them again before you leave on the table just in the area over there. So our agenda for this evening, we have 3 speakers and talking about different topics. And I will just introduce those speakers for you now. So first up we have Dr. Anna Lewis. Anna is an Associate Professor. She's the Queensland State Manager for Health and the National Manager for Indigenous Health at the Heart Foundation. She manages a team of health professionals to advocate and work towards improving heart health outcomes in Queensland. With undergraduate and postgraduate qualifications in health, safety and wellbeing, Anna has been working in the area of cardiovascular disease and chronic disease management for the past 30 years, for not-for-profit and government organisations as well as academic institutions. So Anna will be talking about absolute cardiovascular disease risk assessment and heart health checks. Then next up we have Dr. Sam Manger, and he is talking about lifestyle medicine. So Sam completed his Bachelor of Medicine, Bachelor of Surgery and Bachelor of Science at the University of Queensland. He's a general practitioner and fellow with the Royal Australian College of General Practitioners, where he received an award for the highest score obtained in the fellowship examinations. That's fantastic. He is the president and a fellow of the Australasian Society of Lifestyle Medicine, which focuses on managing conditions with lifestyle measures including nutrition, movement, mind states, social connection, connection to nature, online and advanced technology, health coaching techniques and public policy evolution. Sam's a rural GP in private practice, a senior lecturer and medical educator with James Cook University, vocational medical officer with Queensland Health and host of the GP Show podcast, the GP Show podcast. And then we have, to finish off our evening, Andrea Love. Andrea is going to talk about My Health for Life. Andrea is an accredited practicing dietitian and senior heart health coordinator with the Heart Foundation. Andrea completed her Bachelor of Nutrition and Dietetics in 2015 with the Queensland University of Technology and went on to obtain a Master in Public Health, majoring in health promotion. She represents the Heart Foundation on the Healthier Queensland Alliance, who coordinate and support the statewide delivery of the My Health for Life program, an evidence-based behaviour modification program assisting Queenslanders in reducing their risk of heart disease, diabetes and stroke. So I'm going to stop talking now and I'm going to hand over to Anna, who's going to start us off with our education session this evening. Thanks, Anna.
All right, thanks very much, Susan. So as Susan said, I'm Anna and I work at the Heart Foundation. Can everyone hear me clearly up the back? Yep.
This way a bit for you, like that, so you have to talk into the mic.
All right, how's that? Can you hear me as well? All right, I'm going to have to look here though. So I'm going to talk a little bit about the burden of cardiovascular disease to start with. I'm sure many of you are very familiar with the stats and figures around CVD, but just to give you a quick overview, cardiovascular disease is the leading cause of death in Australia and it accounts for over 25% of the deaths in our country. We know that 48 Australians die due to heart disease each day, and over 16 people are hospitalised each day for cardiovascular disease. And 1 Australian is dying of a heart attack or stroke every 4 minutes. And CVD is accounting for 12.3% of the total burden of disease in Australia. So things aren't looking too great in terms of CVD, but what we really want to share with you tonight is some of the things that you can do about managing risk and managing people who've been diagnosed. So in terms of risk assessment, we know that 2.5 million Australians are at high risk of having a heart attack or stroke in the next 5 years, and over half of them have never had an event before. So clearly risk assessment by health professionals, including all of you here, and thank you very much for coming along to hear about this work, is really critical in addressing risk and also going on to then manage people who are at high risk of CVD. So in terms of managing risk, we talk about the absolute risk approach. So risk depends more on the combination and intensity of the risk factors than on the presence of a single risk factor, because it really depends on the cumulative effects of the risk factors that actually have then a synergistic effect resulting in what we call absolute risk. So it's a little bit faint, but you can see there in the figure that if you look at the individual effect of either high blood pressure, high cholesterol or diabetes, the individual effect of those risk factors is existent, but then when you actually combine the 3 of them together, you can see that you get much higher risk of cardiovascular disease by looking at the absolute risk or the synergistic effect of the 3 risk factors. So we call this the absolute risk approach. Then looking at absolute risk principles, we know that cardiovascular disease is largely preventable. So around 2/3 of people have 3 or more modifiable risk factors for heart disease. Sorry, I'm struggling to see this. That's better. And so, for example, blood pressure, cholesterol and diabetes. We also know that these modifiable risk factors are very well defined, and I'm sure you're very familiar with the modifiable risk factors. So for example, blood pressure, lipids, diabetes, smoking, abdominal obesity, psychosocial factors, in particular social isolation and depression, and physical inactivity and diet are the modifiable risk factors that we're very aware of. We know that absolute CVD risk is the most effective approach, and I showed you previously in the slide the synergistic effect of those individual risk factors and what we call absolute risk. So we have potentially twice as many deaths from coronary heart disease that can be prevented compared to a single risk factor approach. We also know that targeting therapy to the highest risk groups has the greatest benefit. So I'm going to talk more about absolute risk and the measurement of absolute risk and show you the 3 different groups from low, moderate and high risk. And what we tend to do is target the higher risk groups to have the most benefit. And finally, CVD risk calculators are essential. So we know that by using CVD risk calculators is going to be more effective than just clinical judgment in managing your patients. So what is absolute risk? It's outlined in the absolute risk guidelines, and on your seat tonight we have put 3 different documents. 2 are from the My Health for Life program that Andrea will be talking about, and the other one is the absolute risk guidelines, and it's just the summary document. The full document you may have seen, it's available online, it's many more pages than that. But essentially these guidelines were first written in 2012 and are around the management of absolute cardiovascular disease risk. They were developed by the NVDPA, which is the National Vascular Disease Prevention Alliance. The Heart Foundation, where I work, is a member of the alliance, and they were published by the Stroke Foundation. They provide guidance on assessing absolute CVD risk, but importantly managing people to then reduce their risk. And Sam's going to talk a lot more tonight about actually managing risk, focusing on lifestyle behaviours. And the guidelines are consistent with what's in the Red Book that you'd be quite familiar with, I'm sure, as well as what's in any national guides for prevention for Aboriginal and Torres Strait Islander people. And I've shown on the slide one of the guides there. I wanted to also highlight that the absolute risk guidelines were developed in 2012. They're actually due to be revised, and we're in the process of doing that. Just within the last 2 weeks, the Heart Foundation have appointed a project manager to start looking at revising the guidelines, and we're in the process of doing that. Some things do need to be changed. And one of the, I suppose, recommendations that needs to be changed is around Aboriginal and Torres Strait Islander people. So in March last year, we released a new consensus statement for Indigenous people, and we now say that CVD, individual CVD risk factor screening should be conducted for any adult over the age of 18, but absolute CVD risk assessment should be conducted on people over the age of 30 who are of Aboriginal and Torres Strait Islander background. In the absolute risk guidelines, it still says 35. So there has been a change, and we obviously can't update the current guidelines, but in the future review of them, that change will be made. So what is absolute risk of cardiovascular disease? I'm sure you're very familiar with what we mean when we're talking about CVD, but we're referring to coronary heart disease, stroke and other vascular diseases, including peripheral, arterial and renovascular disease. And when we're talking about absolute risk, the actual definition is it's the numerical probability of a CVD event occurring within 5 years, expressed then as a percentage. So I've just got an example there that I think is pretty self-explanatory. For the target group for absolute risk assessment, we recommend that all adults over the age of 45 who are non-Indigenous and without known history of CVD should receive an absolute risk assessment on them. And as I mentioned earlier, the guidelines still say that for Aboriginal and Torres Strait Islander people, we recommend it's for people over the age of 35. But remember, the new consensus statement now says 30, so we recommend 30. What's actually measured in absolute risk assessment is the modifiable risk factors for CVD, including smoking, blood pressure, lipids, waist circumference and BMI, nutrition, physical activity and alcohol intake. In terms of the non-modifiable risk factors, they include age, sex, family history and social history, referring to ethnicity, socioeconomic status and mental health. And in particular, like I said, social isolation and depression are quite critical when it comes to cardiovascular disease. And then also when looking at absolute risk, we encourage you to look at the related conditions, so diabetes, chronic kidney disease, familial high cholesterol and evidence of AF as well. And then once you've done the risk assessment for absolute risk of CVD, management is obviously important, and it depends on the risk level that you calculate. So essentially you're aiming to reduce their risk of CVD and doing this by managing all of their individual risk factors. Clearly that needs to be done in an individual way, but not just managing one of the risk factors, managing all of them. I've got listed here just a list of conditions where you don't need to do absolute risk assessment if your patients are presenting with these conditions because they are already considered at high risk of CVD. And this is for any non-Indigenous person over the age of 45 or for Indigenous people who are over the age of 18. And it's all listed. All of what I'm covering is in that document that was on your seat, which, as I said, is the summary of the absolute risk guidelines. So you'll have this list of conditions as well. As for the process, as I mentioned, for anyone who's over 45 who's non-Indigenous, 35 who's Indigenous, as detailed in the current guidelines, the process is to assess the CVD risk factors that are listed there that I've already mentioned as well, to calculate absolute CVD risk, and then to go on and manage risk, as you'd expect. I'm just going to give you a bit more detail about this now. So the way to calculate absolute risk, there are a few different ways to do it. So one is that you can use the website, which is the online calculator, cvdcheck.org.au. You can jump online and enter your patient's details into the online calculator. It is also built into practice software. So for some of you, it may well be in your software already. I'd encourage you to have a look. And also, again, that summary of the guidelines that I've left on your seat, there are the risk charts you can use. So you can manually, once you have their information, you can actually look up risk using the charts as well, if that's all that you have available to you. Can I just get a show of hands from people who have used any of these different tools to measure risk? Fantastic. What tool are you mostly using? Is it the online calculator or is it in your software? Yeah, brilliant. Yeah, I encourage you. Obviously, it's much easier for you to do that, and it's in most softwares. So then, of course, once you've measured risk, you're going to find out what their risk score is. It's going to come out as low, moderate, or high. Low is if their risk is under 10%. Moderate is if it's 10 to 15%, and high risk is if they're over 15%. And this will come if you're using the online calculator or if you're using any of the other methods, so the risk charts as well. Then what we encourage you to do is, obviously you've identified their risk, you want to then discuss their risk and the options for management with them. You want to initiate blood pressure and cholesterol lowering medication for your high risk patients. We really encourage you to provide lifestyle advice. Like I said, Sam's going to give you a lot more information around that, tips from him working as a GP around how he does it. And then obviously you're going to be addressing those modifiable risk factors. So largely they are smoking, nutrition, alcohol and physical activity. And this is also included in the SNAP guidelines developed by RACGP. We do recommend interventions and referrals for support to lifestyle programs. Andrea is talking tonight about the My Health for Life program, which is our Queensland government-funded lifestyle management program. We're going to strongly encourage you to refer your patients to that program. It's a fantastic program, if we do say so ourselves, but the evidence is really strong for this program. It's free, it's available to your patients, and they can either take part in a group or over the telephone and do telephone health coaching. So you can be referring to that program, and I'll mention some other options as well in a moment. And then we want you to implement a plan for ongoing management and assessment of cardiovascular disease risk. In that same handout, there is a table shown here, which is the risk management summary table. So I know you can't read all of that, but it is in the handout there for you. And it tells you what you need to do in terms of lifestyle management, pharmacotherapy, what the target should be for people, and then ongoing monitoring, broken down into the high, moderate and low risk categories that you will have identified once you've done the risk assessment for your patients. So I'd really encourage you to have a look at it. In a very messy way, I've highlighted there the lifestyle sections, because that's what we're really wanting to emphasise today, is that for all of your patients, whether they're low, moderate or high, we encourage you to look at lifestyle management for all of them, focusing largely on those smoking, nutrition, alcohol and physical activity risk factors. Are people familiar with the new MBS item 699177? Can I see a show of hands for people that have been using the new item numbers? Yep. So in April 2019, our federal government released two new item numbers, 699177 for the non-vocationally registered GPs, This is for what we call a heart health check, which is essentially absolute risk assessment with a bit more around it, and I'll talk you through that. So it's for people, as expected, with absolute risk who have no known CVD over the age of 45 years. With the new MBS item, it has been adjusted to be consistent with the new consensus statement. So that's over the age of 30 for Aboriginal and Torres Strait Islander people. The duration when you're using this item number is that you need to spend 20 minutes with them, and then risk assessing them using the same risk factors that we've talked about. You do need to calculate and record absolute risk once you've conducted that. And then there are requirements around the interventions as well. So discussing risk and options for management with them, providing lifestyle advice, recommending interventions. Again, we can suggest some for you, including the My Health for Life program. Initiating blood pressure and cholesterol lowering medications for your high risk patients, consistent with the guidelines, and implementing a plan for ongoing management as well. We recommend that you do implement reminder systems to recall your patients as required, and you can use this item number once per patient in a 12-month period. And I do have more information if you're wanting to know how you could use this compared with some other MBS items around risk management or chronic disease management, but you can't claim it. Just in summary, you can't claim it with the other health assessment items that I've listed there if you've used those in the last 12 months for that patient. We really encourage that you think about using your primary care team. So the requirement is there, point 3, is that the GP does need to actually assess risk and recommend what the patient should do. However, you could use, if you have available to you, a practice nurse to look at the other steps around risk assessment and management for your patients. So you can see that the practice nurse could perform a record search to identify patients. They could collect CVD risk factor information. As I said, the GP then comes in, then the practice nurse can provide lifestyle advice, etc. So the monitoring and the follow-up can be done by the primary care team. It doesn't have to all be done by the GP. So I said I'd talk about some of the resources that we have to support you. These are some of the resources that are on the Heart Foundation website. So we've done some educational webinars that have been recorded where we've talked through some of the tips and challenges around heart health checks. The absolute guidelines, we've talked about those. We've got fact sheets, other information on our website. But what's probably most exciting is just last week we released a new heart health check toolkit, is what we're calling it. We've got copies on the table outside, and it's just an overview of the toolkit. It's available on the Heart Foundation website, and it's got all of the information that you would need to support you around doing heart health checks. So it's got health assessment software templates, a management template that you can use to provide education and set goals with your patients. It's got waiting room posters that you can download. We've printed some copies. They're the posters that are rolled up, and there's 2 different versions. They're the same in effect that they have a QR code on them that will help you and your patients to access the information. We have recall recipes, and there's quality improvement activity ideas as well, so that you can tap into quality improvement activities in your practice. So there's information for you, but there is also information for you to give to your patients that you can download. You can also, that's not looking too good, Susan. That is meant to be the cover of the Brisbane South PHN CVD toolkit. I'm not sure if people have used that toolkit before, but it's available online. Brisbane South PHN have got, I think it's 25 toolkits, isn't it, Susan? And one of them is specific to cardiovascular disease. I'd encourage you to have a look at it. It is available online. If you can't find it, the PHN or I'm very happy to send it to you. But it has a lot of this information in it as well. Brisbane South, we're ahead of the game. We've developed this comprehensive toolkit. They already had this really good module that was out there to support you with lots of information around how to do heart health checks. And that activity is just one of the activities that's in the module. This is another tool that the Heart Foundation have developed. You may have seen heart age calculators before. Other organisations have developed them. The Heart Foundation developed one a few years ago. And what we're trying to do is motivate consumers as well. So it's on our website. and we'd encourage you to promote this in your waiting rooms. So what we're trying to do is get people to go on. It is, some would say, more of a motivational tool. It's not a clinical tool. But they can go in, they answer questions, and then they find out what their heart age is compared with their biological age. If their heart age is older, we then encourage them, if they're in the right group, to go and see their GP to have a heart health check and actually have their blood pressure and cholesterol measured. So I'd encourage you to recommend that your patients jump on and start to play with this themselves as well. In addition, on our website, we have a couple of animations. We've got one there on the right, top right, that is more for a mainstream population. And it's just a short animation about what a heart health check is, to try and encourage them to go and see you, to have a heart health check. And down the bottom is a new animation that we developed just recently, and it was developed in Western Australia with the Pilbara Indigenous community. And what we're trying to also do is encourage our Aboriginal and Torres Strait Islander peoples to go and have a health check, which may well be done as part of a 715 health assessment, or it can be done in any number of ways, but essentially to go and also have a heart health check. We've got a number of other patient resources and programs. So we've got just a few of them here tonight, but they're on the table also, and it is a brochure for consumers around heart health checks. You can order them, and I'll show you in a moment how you can order free resources from the Heart Foundation website. Next to that is a template that's from the Heart Health Check Toolkit that you can use with your patients to develop a lifestyle management plan or a management plan if they're at risk. And we have a range of food and nutrition resources. More recently, we've been working really hard to try and translate our healthy eating principles into practical tools to support people. And the best way to do that is to develop recipes, so that we're not telling people to go out and buy food or do this. We're actually giving them a practical tool so that they can just go and cook that particular meal, and it is a heart-healthy meal. We've also got meal plans and a series of emails that they can receive if they sign up to them to give them ideas about how to cook healthy meals. And I'd encourage you to also have a look at our website and use the resources. You're probably quite familiar with health pathways. Within the health pathways system, and I have in there the username and password if you haven't used it before, but they also have a cardiovascular disease risk assessment page and information in there that you can access around doing absolute risk assessment as well. This is a snapshot from our website where you can order resources. This is our shop. If you just Google Heart Foundation shop, there's a whole range of resources you can order. You can order up to 50 for free, and they'll just be sent to you. And that's the Heart Health Check consumer brochure that we recommend. I'm not sure if people are familiar with the Heart Foundation walking program, but we have a free walking program where people in the community run the program. They're volunteers. It's an excellent form of social support for people, but also a really great way for people to exercise together. And as you can see in the photo, in some regions within Australia, people exercise within shopping centres, which is great when it's too hot or people might be a bit unsure about walking on uneven ground or outside. We also have groups that do walk outside, and there's groups all over Australia. And you'll find them at the Heart Foundation website. You can identify the groups and then people can sign themselves up. I think there's some benefits from COVID. There's not a lot, but some benefits from COVID have been that we've been looking at more digital offerings and alternatives for how we're going to run programs. And COVID drove the Heart Foundation walking program to think about how could we get people walking, because during COVID we had to stop. We had groups of people coming together. It wasn't safe. So we thought about how could we then do virtual walking groups. So we're now developing our personalised walking plans. That's what they're called. And it's basically where people can tap in to the resource and they can walk on their own or with their family. They don't have to be part of a group. So that's going to be launched very soon. And again, we encourage people to take part in that. I mentioned that we're reviewing the absolute risk guidelines. That's been probably long overdue, but we were waiting for some funding from the Commonwealth Government. As of just last week, we have a new project manager working within the Heart Foundation who'll be leading this work. And we're really excited that finally we'll be looking at the absolute risk guidelines, making some of those changes like changing that age for Aboriginal and Torres Strait Islander people. We also have a coronary artery calcium scoring position paper that will be released very soon. It's been submitted for publication and will be released soon. But in the meantime, we'd encourage you to look at the Cardiac Society, Australia and New Zealand position statement around calcium scoring if you're interested in that. So this is my last slide. Essentially, we know that, which I think is extremely exciting for all of us, that 76,500 heart attacks, strokes and deaths could in fact be prevented with the uptake of heart health checks over the next 5 years. So this motivates me to do the work that I do, and I really hope that you'll become really interested in doing more heart health checks with your patients and having an impact in this way. Thanks very much. Now I'm going to hand over to Sam. He's going to extend the conversation and talk more about lifestyle management in more detail. Thanks, Sam.
Alrighty, well, good. Hello everyone, nice to see your faces. Now, I had a podcast the other day with Sir Muir Gray. I don't know if anyone knows who that is, but he was one of the founders with Sir Ian Chalmers of the Cochrane collaboration, so a very highly respected person in evidence-based medicine. And he told me that we should get up every 30 to 40 minutes and move. So, here's what I'm going to do. I'm going to encourage you all to get up. Let's go. Come on, stand up. Let's freshen up. Oh, we've got one down the front. He doesn't want to do it. There's always one. There we go. We broke him. Okay, so let's just give it a stretch. Let's just get a bit of blood. Up on your tippy toes. That's good. Little twist. Let's get a bit of blood going. Now, the person next to you, if you've got a person next to you, if you don't, that's fine. Scissors, paper, rock. Let's go. Let's take it down. You know how to play scissors, paper? It's 1 or 2 games, scissors, paper, rock. Let's see who the winners are. I hope you know how to play scissors, paper, rock. Very good. I saw a 3-person scissors, paper, rock here. That's very creative. Excellent. All right, I'm watching the games. There's some serious competition going on over here. These two here are still going. It's not just one game. Okay, very good. All right, so let's all sit down. Thank you very much for engaging me. I think it's just good. It's good to freshen up. Makes you feel better. Who feels a little bit better after that? Yeah, you do, don't you? And that's the power of lifestyle medicine. It's instant satisfaction. So I'm Sam Manger. I'm a GP up in sort of towards Mullaney, and a medical educator, as was per my intro. And you can listen more on my podcast, The GP Show, if you're so inclined. And of course, I also like to acknowledge traditional custodians of the land, the Turrbal and Jagera people, and from where I am, the Gubbi Gubbi people, and their Indigenous elders past, present and emerging. Now, no, there's no financial conflict of interest here. I've donated anything that I would be paid to the Royal Flying Doctors Association, and so there's nothing here. I'm pro bono president of ASLM, so no money being exchanged underneath the table. So this is what the goals are today, really talk about the power of lifestyle medicine, the impact of lifestyle medicine on top of traditional models of care when it comes to cardiovascular disease and behaviour change techniques. And then Andrea's going to talk about My Health for Life. I'm only going to touch on it very briefly. So this is how I'm going to lay it out. I forgot to set my timer. It's over there. Okay, someone give me like a 5-minute warning if you can. Because there's 71 slides, okay? So I'm going to get through this. So the first 5 points are going to be about 15 minutes, give or take, and the 6th point is going to be about 25 to 30 minutes. So I'm going to just try and break it down for you. What is lifestyle medicine? Then the role of lifestyle medicine in prevention of cardiovascular disease, and then the role of lifestyle medicine in the cardiovascular disease risk factors, and then the role of cardiovascular disease in cardiovascular disease itself, and related other vascular disease. I had to take a few slides out. Anna told me to take a few slides out. It was 78. And then lifestyle medicine, mental health, just because if you know about cardiovascular disease, you'll know that mental health and cardiovascular disease is bidirectional. You increase your risk of depression if you've got cardiovascular disease, but vice versa. If you've got major depression, you increase your risk significantly of cardiovascular disease. So it's very important to touch on. And then how do we apply this in practice? You know, how do we actually help people change their behaviours realistically? And then maybe just touching on some models of care, because it's not, the more I learn about general practice, I've been practicing for 10 years now, the more I realise actually GPs and nurses try their absolute hardest, and maybe it's the models that are a little out of date. So that's what I like to do. Now, a little reality check first, though, is as passionate as I am about lifestyle interventions, I always say that it's not a cure-all, of course. Some people it's genetic, some people it's social determinants. So They do everything they can, but sometimes it doesn't work. So I always make that reality check. Of course, medications, procedures, everything are life-saving and life-improving. So this is not lifestyle instead of medicine. This is lifestyle medicine or lifestyle as medicine, foundational. It's not about blame, it's about opportunity. So I like to think about what the vision and the future of healthcare will look like. So this is lifestyle medicine in a nutshell, as was introduced. So food, movement, mindset, sleep, stress management, reducing substances, connection with each other and nature, behaviour change, new models of care, technology like biometrics and virtual reality. Biometrics are fascinating, technology that are popping up, research and public policy. And this is a sort of lifestyle medicine model of disease that I've sort of adapted from Professor Gary Egger. And what we can see is what we often look up at the right here, which is the key chronic diseases, like we look down the bottom, coronary artery disease, etc. We're often managing the blood pressure and insulin resistance sort of with medication. And then we sometimes touch on these other areas, but not so much. And so what I'm encouraging us to do is start focusing on those root factors, the determinants of those other factors, because hopefully by the end of my little talk here, you'll get a real sense of how much you can change those markers in chronic disease by those determinants. But to be fair, on modern medicine, has this got a pointer? Yes. We've done very, very well focusing on these areas. 100 years ago, the main problem was pneumonia, tuberculosis, gastroenteritis, dehydration, etc. And we fixed that, right? Mostly. Vaccination, sanitation, antibiotics, trauma, child care, birth, obviously antenatal care. Back in the day, about 100 years ago, about 1 in 5 children died before the age of 4. And about the death rate during childbirth was about 1 in 30, give or take. Now, it's almost unheard of to hear those things. So we've done incredibly well. But the times are changing, and the challenges are changing, and therefore we as the health system need to change with it. 85% of disease burden now is chronic disease, and that's not just Australia, that's globally. It's a huge burden in developing, inverted commas, developing countries as well. So also struggling from infectious disease and other challenges in childhood, but then also now because of the influx of Western culture, these sorts of chronic diseases are popping in. 50% of Australians have one chronic disease. It's a high rate of polypharmacy. The rate of diabetes is tripling over a period of about 10 to 15 years. 5% of Australians have diabetes. Now 15% have pre-diabetes. That's about 20% have diabetes or pre-diabetes. If we think about that in a tripling sense over the next 10 to 15 years, that's not just the majority who are overweight, which is 65% now. We're now looking at the majority have diabetes or pre-diabetes, fatty liver disease, metabolic syndrome. This is a bad direction. 1 in 8 Australians are currently taking antidepressants, including 100,000 children. I think it's the second highest in the OECD. And antidepressant prescribing doubled before COVID in the 10 years preceding COVID. Now it's gone up another 20 or 30% since COVID. So this is a major, major challenge that we're facing now. Obviously that means healthcare costs are going up as well. So if we don't change direction, we may end up where we're heading, right? Where we've got a massively growing burden of chronic disease. And this is not just about an aging population. This diabetes, pre-diabetes, obesity, metabolic syndrome, fatty liver disease, gout, these are all occurring in young people. I mean, I'm sure every GP here is starting to see heart attacks now in like early 40s, even I've seen some in 30-year-olds. This is not a good thing. So if we start looking at prevention of these things, has anyone heard of the blue zones? Yeah, I've got one nod, okay. So there's five zones in Australia, in the world where generally people live at a very high rate. So about 1 in 3 people get to the age of 90 at a healthy state, and there's highest rates of centenarians. So that's Loma Linda, Nicoya, Sardinia, Kari and Okinawa. And there's common ground between these. They have a tribe or a social connection. They move regularly, naturally in the sense of incidental movement, like before talks. They have the right outlook and they eat wisely. So they've got about a 50% lower rate of most cancers. Dementia is almost unheard of. Heart disease, again, much less likely. And we can see that in studies looking at prevention as well. 4 simple lifestyle choices reduces the heart attack risk or heart disease risk of 81% and 93% lower risk of diabetes. Not smoking, BMI that's still overweight, so not obesity, but still overweight, so under 30. About 30 minutes a day of activity and a healthy diet, Mediterranean-style whole food diet. So that's not that hard, massive improvement. And if we look at the individual factors now, so we look at, and I've just taken a few. There's a lot of research here, but I've just picked a few. If we look at the DASH diet, which stands for Dietary Approach to Stop Hypertension, it's essentially a whole food, mostly plants, Mediterranean diet, healthy fats, healthy proteins. a reduction of CVD risk of 13% using the 10-year Framingham risk score. That is massive, and I'll show you how massive that is later. Physical activity reduces the risk of coronary heart disease and stroke, 25 to 15%. There's a number of randomized control trials, but I just picked one that looked at actual all-cause mortality after the 5.5 years that this trial went for. Reduction 48% in all-cause mortality and cardiovascular disease events from meditation. Social isolation also plays a major factor here. So these factors, each in and of themselves, play a major role in coronary artery disease prevention. If we look at the Framingham risk calculator, it's not coming out very clearly, but we know that high risk is 20%, low risk is 10%. So 13% is taking people from a high risk to low risk, just with a simple dietary approach, so not including all the other stuff. It's massive. And if we look at the actual impact of these things on, so this is from the National High Blood Pressure Education Program, so it's the National Heart, Lung and Blood Institute. If we look at the actual impact of these things on high blood pressure, physical activity makes a difference of 4 to 9. DASH eating plan, 8 to 14. Weight loss, roughly about 1 millimetre of mercury per kilo. Stress, tobacco, etc. So there is quite a significant improvement you can make. And I find this, again, if we're talking about behaviour change, using these things and showing people these statistics is very effective because people think, oh yeah, I know I should eat well. Yeah, I get it. But they don't know why. They don't know what impact that's going to make. And when you actually show them the evidence, they get inspired. If we talk about diabetes and pre-diabetes, there was a great paper in The Lancet in 2018 led by Roy Taylor, and he showed that diet alone could reverse 80% of diabetes if diagnosed in the previous 6 years, if they lost 15 kilos or more. And there are multiple dietary approaches that you can use. It can be whole food, plant-based, low carbohydrate, whole food, fasting, very low calorie diets. There's no shortage of approaches here. But the point being is almost all of this is preventable and be able to be put into remission. It is not necessarily a chronic disease that requires medication for life. It's very much a disease that can be put into remission with proper care. So if we look at the cardiovascular disease risk, again, I use this quite commonly because you can compare them, as you know, online. So this is just a snapshot of the page. And you can show people what the difference is when you actually change a few minor things. So this is a 45-year-old male I've plugged in, a mild lifestyle program, so their blood pressure dropped by 10 points, which isn't a lot, cholesterol by 1.5. So this is pretty mild, but I did reverse their diabetes, okay? And it dropped from 10% to 3%. This, much the same, but they stopped smoking, 11% to 3%. This is a diabetic and a smoker who stopped smoking and reversed their diabetes with lifestyle, 18 to 3%. So there's massive impact on cardiovascular disease risk. And this is very motivating because this person needs an ACE inhibitor, needs a statin, needs aspirin, at least, right? So that's 3 medications. This person can just keep enjoying their kale, you know. Some people would prefer this option, I'm sure. So now let's talk about the actual heart disease itself, okay? So this is the Lifestyle Heart Trial, a 5-year randomized control trial that was done a number of years ago and published in JAMA, which is a very respectable journal. So this is, as most of you will know, a coronary artery that's got an angiogram, so that's the dye going through it. This is sort of moth-eaten look of a sort of affected coronary artery that's either going to cause angina or eventually rupture and cause a heart attack. This is after 3 years on a lifestyle program, nice and clean. And what they saw in this after 5 years was a difference of 35% stenosis, which is, again, a significant impact. Because what you're going to see there is you're going to have one person with 70% stenosis, and what do they need? Well, they usually will need a stent, and maybe if that's around the whole heart and multiple blots, they might need a CABG. Versus a person with 35% stenosis won't need anything, right? They'll just be monitored. So there's a very big difference. And again, there was a 2014 paper here, which was a 4-year study looking at 200 people, which applied much of the same thing, and they saw, again, much the same thing. Significant reduction in the number of procedures, almost complete resolution in a lot of people's symptoms, and those who didn't adhere ended up going on to having CABGs, transplants, stents, etc. And I mean, much like many of my patients, stubborn old man syndrome who don't want to engage, especially in cardiac rehab for some reason. But this is just a nice little paper, I thought, because it showed that some people get no difference in their health status. So a lot of men, especially I'd find, not trying to generalize, but I do find it to be true. No, I don't want to do that. It's not going to make any difference. And symptomatically, that may be true. They may not feel that difference after a year or two of having a heart attack, whether they do cardiac rehab or not. But the risk is significant, 41% reduction in the chances of all-cause mortality. But then there's lots of other studies that show they get improvements in mood and symptoms, hospitalisation. So cardiac rehab has a huge impact. If we look at atrial fibrillation, very common disorder, most common arrhythmia. If we look at the guidelines, this is copy and paste from the guidelines, managing risk factors, okay, which we talked about, alcohol excess, weight, sleep, like obstructive sleep apnea, and exercise, all have moderate grades of evidence, which is very good for one of these high-quality guidelines. Strong recommendation. That's as good as the CHADS VAS score. So this is, all of these things here have been shown that if you treat and manage obstructive sleep apnea, if you get people exercising, if you get people losing a little bit of weight, it helps their heart rhythm go back into sinus rhythm, which is obviously what the goal is. It helps maintain that sinus rhythm, it prevents reoccurrences, and it improves their symptoms. So this is just evidence-based medicine. The same is true for heart failure much. I just put this in because I think it's always interesting to look at the nuance in papers, but they just saw that actually it was a lot more effective exercise, for example, in women. So I just thought that was interesting. But the point being is that there's a number of factors at play here at almost every level of whether it be the risk factors or the disease process itself, this stuff works. If we look at stroke, again, randomized control trial, 70 people, 3 years, split into 2 groups, about 35 people each group. 12 people in the control group, which is treatment as usual, went on to have a stroke. That's about 30%. That's pretty standard. About one person in 35 had a stroke who went into the lifestyle program. And I'm keeping in mind that lifestyle programs are real. Like, not everyone adheres to everything that they should do. There's a spectrum of adherence. But that is very impressive. And I was going to talk about dementia because that's largely a vascular, well, it's got a strong vascular component. And that is also showing significant promise in this area. But I got rid of those slides. So when we look at mental health, like I said, depression increases the risk of heart disease by 64%. For those who have had a heart attack, the presence of depression carries a 5 times increased risk of heart mortality in the 6 months. This is terrible, with common factors at play here. We're talking lifestyle factors, autonomic dysfunction, hormone imbalance, inflammation, insulin resistance. So all the things that lifestyle actually plays a role in. And if we look at depression itself, we can be proud of this because it's some Australian research and done by Professor Felice Jacker down at Deakin. And 32% of patients with moderate to severe major depression, so not mild depression, I'm talking moderate to severe depression, went into remission with a modified Mediterranean diet versus 8% in control. Then they did a meta-analysis of randomized controlled trials, so this is prospective, good quality trials, not epidemiological studies, though they are good, but not those. 45,000 people showed a similar finding. So this is having a huge impact on people's mood as well, because it affects these root causal factors. It affects inflammation, it affects hormonal function, it affects your microbiome, it affects neurogenesis. If we look at movement, again, movement consistently, the European Psychiatric Association guidelines updated in 2018, because there was just so much overwhelming evidence that movement is so effective in depression, as effective as antidepressants, psychotherapy, improves quality of life, and even for schizophrenia spectrum disorders, reduces psychiatric symptoms and improves cognition. So this is something that is just so applicable to everyone. But the question is anyone listening, right? I'm not talking about you. Hopefully you are listening. But sometimes it feels like patients aren't listening, right? You can go on about this stuff, and you're like, why aren't people changing? So that's why it's so important. I'm probably way over time already, but let's just see how we go. Because the thing is that this area of persuasion or behavior change is very well studied, but not in medicine. It's studied by marketing people, right? People who want to sell you products. People want you to usually buy not great things for you. Advertising, et cetera, et cetera. And these are all books, a lot of them I've read, and there's common ground amongst a lot of them, but there's something here that we can learn as a health profession to help people actually change. Obviously, the social factors are so incredibly important, and we need to get rid of sugar that's at every corner in our society. But talking about what we can do in our clinic for now, we can think about the individual lifestyle factors, we can think about the community factors, and we can think about the social environmental factors. Like I said, these are absolutely crucial, and as a profession, I think we should join together in a lobby, but that's another conversation for another day. So now behaviour change. So what I was thinking about this, because I think there's so much, right? Because there's at least 200 to 300 hours of content when it comes to health coaching and behaviour change. There's diplomas in this, there's university degrees in this. This is not a small area that you can just summarise in 15, 20 minutes. But I thought, okay, well, there's practice nurses here and GPs primarily, I assume. So what I'm thinking is, how can we enhance the good practice that we're already doing? How can we just tweak maybe a bunch of things to optimise what we do? So I thought I'd share some of that. So I'm going to go through the definition, the evidence, some myths and facts about health coaching, some principles, practical tips, referral options, tools, further training, built environment / nudging, and models of care. Just to give you a pretty, hopefully a comprehensive but short and succinct version of what we can do. So health coaching is essentially this patient-centered process working in a relationship, which is a lot of, I'm talking to the, I probably shouldn't say this on camera, but we're talking to probably the warmest of the medical profession here, GPs and practice nurses. So this is stuff that will be very familiar to you. And when you're using a variety of tools, non-judgmental, effective communication, and goal setting. There are so many different types of theories, and I'm not going to go into all of them. You've got all these, plus the list just keeps on going. All right, so I'm going to just focus on a few little things that I think are the practical overlaps that we see in a bunch of them. You can be quite confident because in the last 15 years there's been a significant escalation of evidence in this area, including in randomised control trials. I think it was 1 or 2 years ago, the Health Coach Australia and New Zealand Association popped up to establish standardisation processes, accreditation processes for this. So it's becoming a lot more legitimate than it was, say, 15 years ago. And it's not just about lifestyle, because the medication adherence is extremely poor as well. I mean, a lot of studies say medication adherence can be as about 70%, 50% give or take. And that leads to a variety of problems, whether it's death, hospitalizations, and cost. So this is not just about lifestyle. Health coaching can be applied to anything that we do. Why learn to do it? Because we get better patient outcomes, better patient adherence, improved patient satisfaction, improved job satisfaction, the studies show, which is great because it's lovely to love your job more efficient appointments and less complaints, which is also nice to not live in so much fear. And there is a range of evidence. This is a nice little sort of compendium or meta-analysis that was done a while ago. And health coaching outcomes in cardiovascular disease specifically, there's evidence for all of these things. Confidence, nutrition, exercise, smoking, alcohol, BMI, blood pressure, cholesterol, sugars, stress, anxiety, and lower cardiac hospital admission rates. So it definitely has a role in cardiovascular disease. When it comes to myths and facts, the two most common things I hear from practitioners is it's too time consuming and it doesn't work. So the first thing is it's not too time consuming. When they've done randomised control trials in this area, they say it's no more time consuming but more effective, GPs who do this training. It's pointless, it won't last. Well, again, systematic review of motivational interviewing techniques demonstrate they last for up to 4 years after an initial period. So there is significant impact of these things. So here's just a few principles that I thought I'd share with you. Like I said, there's common ground here between the trans-theoretical model of change, which is where motivational interviewing is sort of loosely based on, and other self-determination theories and other sorts of theories. The first thing is to have realistic expectations. I always say that first, because in my experience, it goes in the rules of 3. 1/3 of people are quite happy to change pretty quickly. 1/3 of people need about 4 to 6 months just to think about it, reflect on it, plan it, etc. And another 1/3 of people are just not interested. And they might take sometimes 2-3 years, but you still play the game, and they sometimes come back and say, oh, I ended up quitting smoking. Remember, you talked to me about it 3 years ago. So just keep in mind that you're not going to win with everyone. That's really important to remember as us as practitioners, because we get jaded if we don't win. Don't worry about it. Just do it anyway. This is the general principles of any behaviour change. It starts with intrinsic motivation, which means we or someone is pushing them. It's an advert, it's us as the doctor, it's their family member. It's something that's trying to tell them to change, but they don't really want to do it themselves. Then it goes to intrinsic motivation, meaning that they start to feel the internal motivation themselves. I'm sure we've all felt that a little bit. So that's when it actually starts matching our values or what is important to us, or it is actually pleasurable. And then habitual, which is where you want to get people to. That's the kind of end goal, that's the money point. Because obviously when things are habitual, which can take some time, studies say different things, 62 days, 21 days, who knows, but it takes some time, it's different for everyone. That's when it just becomes an automatic behaviour and they just incorporate it into their life. That is where you're aiming for. So how do we get people from extrinsic to intrinsic? Well, that comes down to this quote sums up almost all of health coaching. Tell me I forget, show me I remember, involve me I understand. And I'm going to talk about this in the next slide, which is the personalisation required when you're going through the health coaching process that is an assessment and management process. You have to personalise it to the person. There is no two people alike, whether it's genetically, socially, lifestyle, biologically, culturally, etc. We have to personalise it. And to do that, we have to know the person. We have to take a detailed history. We have to match the management accordingly. But then we have to involve them in goal setting. Now, many of you will hear about goal setting, and there was some good resources there. And you may have heard of the SMART goals, which is specific, measurable, achievable, realistic, timely. And that's a great way, a little platform to use. I don't know, do those handouts have smart in it? Yeah, maybe? Not so. No, the handouts you mentioned. Yeah, okay. And then then you got them engaged, right? And I'm going to talk about that a little bit more in the next slide. Then you've got them setting some goals, and then follow-up is so crucial. There's a few things. Frequency of follow-up. What I see so often in whether it's journals or articles or teaching is that, and real life, is you see the person 6 months later, 12 months later, catch up with them once a year. That will not work. This is the NHMRC obesity guidelines. Their recommendation is you see them fortnightly for the first 3 months, and then continuing at least usually monthly for 12 months after. Sustained weight loss is unlikely a result from episodic care, but needs to be actively managed and monitored. We need to be proactive with these patients. You need to book them in for a follow-up. And the great thing about the services of today, like Mayo Health for Life, is that you don't have to do that. You've got 6 free health coaching sessions that you can utilize for the patient. You can get them to see them every 2 weeks. What I generally do is I get them to hook in with My Health for Life. I see them monthly, and I get My Health to see them monthly, so they get seen every 2 weeks for 6 months. I think my maths is right there. It might not be. And then you've got to think about, okay, sources, right? So you're regularly seeing them. You don't want to burden yourself, because most of us as GPs have like a significant wait list. So there are other sources of follow-up. There are other sources of support. I mentioned My Health for Life. There's your allied health. There's your practice nurses and the item numbers within that. But there's also social prescribing. There's other community like park run or walking groups or shared medical appointments, other things like that where people can start supporting themselves. And the goal of follow-up is obviously to monitor their goals, monitor their motivation, monitor the barriers and see that what comes up, because barriers they will definitely come up. Like nothing is ever smooth in behaviour change. And then to help them facilitate and overcome those. And then change yourself is another really important principle. I mean, if I assume everyone here has tried to improve themselves at some point, whether it's to go to bed earlier, wake up earlier, eat more vegetables, exercise more, something like that. I assume everyone's experienced that. I think one person here is saying don't fall asleep. That's them trying to change themselves. Long day. And so when we do that ourselves, we learn it's actually really hard to change behaviour, right? And so when you go through it yourself and very active of your own processes going through your mind and body and social situation, is that you can share that with patients. Lived experience is so crucial. And if you share that experience with the patients, the evidence shows that 1, they respect and appreciate what you're saying. 2, they're more likely to change and then will be more successful in that change. So if we talk about just a bit more detail here, relationship is so crucial. This is something I think GPs and practice nurses do exceptionally well already, so I'm not going to spend a lot of time on this. But what I see, because I do obviously a medical educator, I do a lot of ECTs these days of GP registrars, and what I see is a lot of sinking into the screens. Okay, so what we learned in general practice is to have that golden minute. Sit back, just listen to the patient for at least a minute before starting to ask closed-ended questions. And it's so true. The same is true in coaching. Sit back, get off your screen. Even a very powerful tool is to switch off your monitor just for a moment. Really demonstrate to the patient that you are wholly attending to them for a short period of time. Reflective listening, repeat some keywords back to them. Be present in the consult. Then it comes to history and management. So the thing I'll say here is that for some reason we treat lifestyle as if it's different from every other part of medicine. We think that we can just give people a handout on healthy diet and then that's all we need to do and it's their fault that they don't change, right? We got this really old, out-of-date, paternalistic model of lifestyle interventions. The truth is it's like every other medical condition. If you've got a patient with a headache and they come in, they say, I got a headache, and you go, yep, that's the diagnosis, headache, here's some Panadol, then you are a terrible doctor, okay? And so it's the same with lifestyle. If someone comes in and you say, how's your diet? And they go, yeah, pretty good. All right, well, it's not that. Can't be that. Okay, you're a bad doctor, no offense, but that's the case. You've got to take a detailed history. What do you eat? When do you eat it? When are your urges? When do you, etc. So what is breakfast, morning tea, lunch, afternoon tea, dinner, snacks, after, before bed, overnight, and drinks, okay? You've got to ask those things because what you'll find, like anything, if you take a good history about headaches, you'll find it's a cluster headache or a migraine or a tension headache or cervicogenic or whatever. It's the same with this. You're going to find that it's a binge eating disorder at nighttime, or it's that they are a truckie and they drive and they eat like loads of chips while they're driving. You're going to find the diagnosis, and that's the goal of what we do, right? So printing off a one-pager for most people, I find to be a useless activity. you have to take a history. You do that with sleep as well. You do that with exercise. You do that with stress, and you have to manage the actual problem, manage the actual diagnosis. And when you're setting up a management plan for these people, and you're talking about personalization, so that's what I meant by personalization before, you're basing your management off the history. It's really important to set up early wins, because like I said back here, if you want to get people in this intrinsic area, they've got to feel that it matches their values and or it's enjoyable, right? So if you give them an early win in an area that matters to them, you're going to tick those boxes, they're going to feel a sense of success, and then they're going to want to keep going. And I will say this last little thing, detailed education of our reasoning. Again, I think primary care is pretty good at this, but it's very powerful to educate people, like I showed you tonight, where you actually show them the pictures of the angiogram, or you show them the studies, or you show them maybe like a picture of diabetes and how that's caused with intracellular fat disposition, and when you reverse that, you reverse insulin resistance, they can then put the sugars back into the cells, bang, you're done. This is very powerful, because then people feel like, I understand now what's wrong, and I have some power over how to change it. And that's what you want them feeling. And when you've then said, okay, well, here is the raft of options that will have an impact on your, let's say, depression or heart disease. We have diet, we have exercise, all these things make a difference. Which of these would you like to choose? Which of these today do you think is something you'd like to engage in? And it is unlikely to be everything. It'll be exercise or sleep or stress management, which are usually the three quickest things to make people feel good. Food takes some time. And then again, now you're taking people into that self-management process where they're deciding what they want to do. You're helping them set goals using the SMART framework, and then you're following up with them regularly. So hopefully you can start to see how all of this molds into a much better behavior change process and support process. Now, this is a couple of little tools. This one I wrote based on Dr. Wayne Dysinger in America. And this is at my website, the GP Show, if you want to try it. And it's a rate scale of 1 to 10. How satisfied are you with your nourishment, movement, connection, sleep, stress? And this is a really useful tool, because people, they'll go, 8, and they'll go 1. And you're like, whoa, what's going on there? And then you're like, oh, well, I just really hate how much I use my phone or something. And you'll go, okay, well, is that something you want to change? Yeah, it's something that really gets to me. Okay, so it's a really nice tool, if I do say so myself, but that you can use to start highlighting, and people can highlight themselves where they think those money points are. Now, a quick thing about brief interventions, because that's a lot of what we've got time for in general practice. These do make a big difference. So studies show that brief interventions from a GP reduce alcohol consumption significantly. 1 in 8 people drinking at hazardous levels will reduce. 1 in 3 smokers will quit and not relapse after a year. So it makes a difference. But when you add on everything where I've talked about today, where you're talking about intrinsic factors, SMART goals, self-management, getting people to come up with these ideas, following up regularly, you're going to have a much better success rate. This is another tool that we've developed within Society of Lifestyle Medicine, thanks to Simon Matthews, who is a psychologist. And he put a lot of the common behaviour change tools together and made this, the Quick Intervention for Change, which again you can find at my website. It's designed for GPs and primary care. It literally takes about 3 or 4 minutes. And it's just a series of questions that you can ask your patients, and it's another very, very useful tool. What do you want to see immediate change in? What's important to you? So coming down to that intrinsic values. And what's working well for you in a small way, and how do we change this even just in 1 point? So again, we're talking about realistic goals here. We're not saying we want you to start becoming a marathon runner. We just want to start nudging that indices. And you can repeat that. So the thing about motivation, though, it's like bathing. You've got to do it every single day, right? So people need motivation ongoing until it becomes habitual, until it becomes, and largely intrinsic. The extrinsic motivation needs to be every day. So just keep that in mind when you're thinking about follow-up. Is it podcasts that you can set people up? Is it quotes on the walls? Is it inspiring photos? Is it something that they can be primed regularly? There were some fascinating studies when it comes to priming, or which is the condition response, where we associate multiple things together. Where if people listen to music when they exercise, music they like, obviously, they're more likely to keep exercising in the sense of frequency. They're more motivated to exercise for the future. And they exercise for longer without really realizing it. So they exercise for on average 15 minutes longer, and their fatigue is less and their endurance is better. So music, there are these priming or condition responses that you can tap into the brain if you want to. For example, when I work at night, I put on my favourite series just here. I don't really watch it, but just the fact that it's playing primes my mind with, oh, study is good, right? So now I actually really like it, right? I've just hacked my own brain. So it's possible. Now, obviously, I mentioned My Health for Life, and Andrea will talk about that, but it's a great service and you can use for this sort of health coaching support. Now, if you want further training in this area, there's lots of areas. ASLM has a course called Communication Matters. The Heart Foundation have free motivational interviewing videos, which I'll show you in the next slide. Well Coaches and the Health Coaching Australia New Zealand Association have a series place where you can now do weekend courses, diplomas, all the way up to diplomas. So give that some thought. And this, I think, is one of the best books. There's 3 good books. This one for coaching by Mark Moore, who's from America, and then Getting Past No and Getting to Yes by William Ury. Very short books. They're kind of more business orientated, but very good, very to the point. And this is the Heart Foundation Motivational Interviewing series. Very good. Worth checking out, playing on the background, play it while you're in the car, upskill. Now I'm going to talk about how much time have I got? Perfect, sweet, all right, doing well. I'm going to talk quickly about built environments, because what I've talked about largely is about what you can do on a one-on-one individual basis. Now I'm just going to talk about how maybe we can think about shifting our environments, or the environments we can control, like the clinic, to be more supportive of behaviour change. So this is what, I'm just going to mention nudge theory quickly. So nudge theory is a concept that's used in politics and behavioural sciences and economics. It's essentially any aspect of choice architecture, which means anything in your environment, essentially, that alters people's behaviour in a predictable way without forbidding any options or changing their liberty. Okay, so it's not force, it's kind of influence. And it exploits a range of cognitive biases. So this was from Daniel Kahneman. It's not perfect, obviously. It's not that, sadly, humans aren't this simple, but if you break it down at a very basic level, most of what we do, I think most of us can agree, is automatic. It's instinctive, it's habitual. You know, we drive, we realize, oh, how did I get here? It's just automatic. We work, it's fairly automatic. We react to things, it's automatic. A little bit of what we do takes significant effort, okay? It's slow and steady and rational, which is, I think, why primary care is so fatiguing, because you use a lot more of this. So what you're trying to do is tap into, because we're running in this 95% of the time, it's a highly susceptible area to external influence, which is why marketing works. It's why you walk into a store not wanting anything and walking out with like 3 products, right? Because they know that they can tap into this. It's very well documented. If you think you're immune to it, you are not. Now there was one little fun study about nudging. This is, I think, in Stockholm, where they painted a little fly on a male urinal because they were sick of the splatter. And they found that all the men just started to want to piss that fly off, right? So it's not forbidding anyone. They can piss anywhere they want. But it just inherently, instinctively, men want to aim for something. So they found that this reduced splash rates significantly. So this is just a little example of nudging. So if there's any people with problems in their house, this might be something you want to try. So in clinical medicine, as opposed to public health, I find this nudging can be useful in 2 major ways. The first is to initiate conversations, because naturally, when you're busy, because GPs manage on average 2.5 problems per 15-minute consult. So, you know, it's pretty hard to reverse someone's diabetes in 4 minutes. And therefore you get distracted. So it's good if you can set up things in the room or in the clinic itself to initiate that conversation for you as an icebreaker. So usually the patient raises it as opposed to you having to remember. The second thing is to commence and maintain behaviour changes. It's called self-nudges. And this is a talk I give that goes for about an hour or 2, so I'm digesting this down into 5 minutes. So there's a lot more here. So the acronym often used with nudging or behavioural sort of influences is called MindSpace. And these are important to know, and you can look up the link down here. There's some really good examples here about how we influence. We're influenced by people who is giving us the message, right? So if you're people like themselves. And it doesn't have to be exactly the way you look. It doesn't just have to be men to men or young person to young person or whatever. It can be simply the way your posture is or the words that you use, etc. Right? So if there's parts of the brain senses that you are like me in some capacity, it then trusts you. And that's just an instinctual thing. Incentive. So the incentives work, we know that, but it's sometimes not always the incentive of positive reinforcements. It's actually the fear of loss that works quite well. I mean, both of these work well. Or the fear of losing a bargain. Norms, which is social norms, which is why social prescribing is so crucial. Getting people into groups like Parkrun is so effective because there's a social obligation. It's why pharmaceutical companies give you things. It's because whether you like it or not, there is a social obligation, a social contract that occurs with that, and now you feel indebted to listen to them. and probably why you're feel indebted to listen to me, perhaps even. But so defaults, which is preset, salience, which is the new things, priming I mentioned before about conditioning response, affect about emotions playing in, commitments, and ego. So these are things that all play a role, and I could give examples about these, but I don't have time. So here's just a few that I have found to be quite effective in an average clinic. The first thing is, for me as the practitioner, autofills. I have a range of autofills, right, where if I just press MX, then I'm going to get something like this just pop up on my screen, because then it's going to remind me to think about my health for life. It's going to remind me about the behavioural things. It's going to remind me about the lifestyle domains and doing a detailed education. And it's going to remind me about booking follow-up. Okay, so that's a nice little nudge or a default option that I found very effective. But you can also alter your clinic. So if you put a poster up, so if let's say the patient's sitting facing this way in your room, you put a poster up on the wall there that says, would you like more time to discuss lifestyle options for your health, book a double appointment, you're normalising it. And patients are going to ask, oh yeah, I didn't know you do that, I'd love to book a double appointment. Yep, great, no worries. So you're doing it for you. Putting running shoes in the corner of your room or a bike helmet on your desk or an apple on your desk often starts conversations. So, do you exercise, do you run, doc, or do you ride? Yeah, I do actually. Yeah, no, it's really good. I feel really good afterwards. It was quite difficult to get into at first, but now I'm really enjoying it. On goes the process. So that's salience and priming. People notice those things that just look a little bit different. Text reminder systems are something I think that are well and truly underutilized in primary care, because you can frame language in such a way that makes people, that incentivise people. They're working on their ego or some sort. Pantry and fridge flip, it's a tongue twister, but is repositioning healthy and unhealthy options. So I don't know why, well, I think I do know why, it's big food, but that vegetables go in a drawer hidden at the bottom of the shelf, and all the crap food goes right in front of you, right? I mean, it's weird. So put all the bad food in the drawer and put all the vegetables on the shelves. Okay, so that's one way you can get people straight away to start thinking about that as a first option, and just put one barrier in between that and that food. Or give them a pantry flip, where you just get them to have a bit of a clean out, donate a bunch of stuff, and keep the healthy stuff. So you're changing the default. Same with plates. Smaller plates, the evidence shows, do lead to smaller portions. Same with smaller cutlery, interestingly, but that's another thing. And social groups, as I said, and remember, those social groups don't always have to be in person. They can be online. There is a lot of, well, not a lot, but there's not good stuff about social media. I think we all know that. But there's also a lot of good that comes from social media. And one of those things is closed Facebook groups. There are millions of people now supporting themselves or supporting their peers because of closed Facebook groups. And there are good ones too. There's always weird stuff in there, but if you work with your patients, you can navigate that and teach them how to critically appraise well. And then they can get a lot of support, a lot of motivation. So I mentioned that the burden we have, and these are frequently cited barriers in the literature, which I think we can all recognise as true: time, funding, support, training skills, knowledge, burnout. So hopefully you can see that I've sort of accommodated time. Funding is a tricky one. Support, training skills and knowledge, I've talked about today. Burnout, like I said, improving your own health is one of the best things you can do for your patients. So the question is, do we need a new model? Because it's great. Drill presses work. Medication surgery undeniably work. But sometimes you don't need medication surgery. Sometimes you just need a hammer or a screwdriver. So the question is, do we need to change things up a little bit or add another tool to the toolbox? And I would argue very strongly yes. Now, whenever you're making a new model of care, you have to consider the barriers that are in front of you. Is it the barriers to us, i.e. denial or confidence or skills? Is it the patient, knowledge, health literacy? Is it the healthcare system, or is it socio-cultural? One of the most common barriers I get asked by health professions, not so much patients, is, but it costs so much more to be healthy. Well, this is a meta-analysis and systematic review. This one showed that it's about $1.50 more per day, or $10 a week, to eat a very healthy, whole food, plant-based diet, with some healthy proteins like meat or plant-based protein. So it's not that much at all. Most people can afford that. And other studies actually show it to be cheaper, because believe it or not, which I'm sure you do, soft drink, for example, is very expensive. It's just calories and crap. It's poison, but it's actually very expensive. So if I'm just going to mention a few of the models of care that some of our members have come up with. So this down here is Dr. Michelle Rees at Central Coast in New South Wales, created the it's now called, I think, the Life Medicine Centre. So she uses lifestyle medicine first line. That's what people expect. And there's a whole support system around that, a whole interdisciplinary team, the nurses, the allied health that work together, that meet with each other in a multidisciplinary fashion, and they support that person with shared goals. They have classes and community events, and they do shared medical appointments, which I'll come back to later, which are essentially group appointments, like you can see down here. This is me, obviously, pre-beard. This is on the Sunshine Coast, one of the psych units that I work at. This is Dr. Linda Barron, who's a psychiatrist. This is Scotty, who's one of the mental health nurses. And here we run a whole bunch of lifestyle programs for the psychiatric patients, including a lunch which they cook and we all eat together. Again, just changing the culture of the place. Now when people come, it's expected that they join the lifestyle programs. It's not an addition, it's not an adjunct, it's not complementary, it's standard care. Shared medical appointments, I mentioned before, now has a very large body of international research, improving outcomes, satisfaction, rural areas, indigenous populations, mental health, physical health. It's basically when you get a whole bunch of people together in a room who have the same condition, heart disease, diabetes, depression, whatever, and you spend 60 to 90 minutes with them, and the doctor and the nurse facilitate that. You can bill Medicare, and therefore patients now get 60 to 90 minutes with their doctor, and they learn from each other, which is probably one of the most powerful things. When you start to see people sharing knowledge between each other, supporting each other in the community, when they're out at the shop, they're looking at each other's shopping baskets going, you shouldn't eat that. So, you got this constant little social support occurring. Here's one study that was published in 2019 about this. So, as if not more successful for weight loss than individual therapies, 3 out of 4 people said they preferred it to standard consults, 4 times more cost effective and 7 times more time effective than one-to-one consults. So here's just a new model, a new way that we can start thinking how we manage these complex chronic diseases that are so hard to manage in one-to-one care. This guy over here is Dr. Glenn Davies, a lovely man, a GP in New Zealand, in Taupo, I think I remember Taupo, I think. Taupo, thank you, apologies. So he runs these groups in his community where they're education events every week and larger events every 3 months. They have a closed Facebook group where they support each other and share resources and that he moderates, or at least used to. And he obviously still runs his usual clinic. And he's now seen 109 patients reverse their diabetes, pre-diabetes. And if you look at similar programs in Netherlands, at 6 months you can see 50% of people reduce their glucose lowering medication, 13% eliminate it completely. So again, an effective therapy. And of course there's online programs. The LIFT program is an online lifestyle program by Associate Professor Darren Morton. And this is it impacts all areas because it's lifestyle medicine, but this is an RCT on mental health. And we've now had about 15,000 people go through this program, and it's been extremely effective. Now, the last thing I'll say is about cost, because a lot of people say, well, this is all costly, right? It costs more to do this. And no, it doesn't. Every study shows that it's more cost effective pretty much. This is a paper in the Lancet Psychiatry, I think 2018 or 2019. Nurse and healthcare assistants trained in cardiovascular disease prevention, such as health coaching and lifestyle interventions, diet, physical activity, smoking, alcohol. What they saw is between about a I think it was about 60 to 80% reduction in admissions and a 40% reduction in total healthcare costs. So this is something that's really effective. And if we just think about the cost of reducing medications, 1 per person per year, it's about $500 million we're going to save. And so the PHN Tasmania has some fantastic de-prescribing resources where they've actually gone through and in a methodical, evidence-based manner, written out these guides on how to de-prescribe people when the time is right, when it's safe and appropriate. So here's a little summary, some take-homes. Building a relationship with people matters. The common ground you see launch a lot of psychotherapies, whether it's CBT, ACT, IPT, etc., is the relationship they have with the therapist. So that matters a huge amount. Detailed education, thorough assessment, thorough history taking, and management. Regular follow-up, using tools like the Quick Intervention for Change. Change your environment a little bit if you can. Consider different models of care. Use My Health for Life or other coaching services that are out there. And consider upskilling, because it's just a fun and rewarding area. So hopefully I've helped show these things, that it's effective for all the different ranges from risk factor and multiple disease states, and it improves patient outcomes, and it's just a fun, enjoyable thing to do. Thank you very much.
Hi everyone. I'm going to make this really, really quick, just considering the time. So I'm just going to give you a really quick overview about the My Health for Life program. I just want to ask quickly if anyone has heard about the My Health for Life program already. I see a raise of hands. Okay, a few. Okay. So the My Health for Life program is a free behaviour modification program, and it's designed to support Queenslanders who are at high risk of heart disease, diabetes and stroke. So this program is funded by the Queensland Government through Health and Wellbeing Queensland, and it's coordinated by the Healthier Queensland Alliance, which is the organisations at the bottom there. So we're led by Diabetes Queensland, with involvement from Stroke Foundation, Heart Foundation, the Queensland Aboriginal and Islander Health Council, the Ethnic Communities Council of Queensland, and all 7 of our Queensland PHNs. So we all work together to deliver a different component of the program. So the way in which it works is we were 6 sessions, we are now 7 sessions across a 6-month period. I have included on each of your seats just a program outline so you can see what the sessions look like. And the program is delivered by trained health professionals, either based in community, in person, in some small groups, or via telephone health coaching, or since COVID we've introduced video conferencing as a mode as well. So the people that deliver the program are trained by our team. They are typically allied health, a lot of dietitians, exercise physiologists, a lot of nurses. So we train them to deliver the program, and they're dotted all across the state of Queensland so that we can deliver the program in small groups in regional locations. So this program has also been adapted for Aboriginal and Torres Strait Islander people, and it's also been translated into a number of different languages, Cantonese, Vietnamese, Mandarin, Arabic, just to name a few. So our multicultural workers over at the Ethnic Communities Council of Queensland, they deliver our program in language. This is both in groups, video conferencing or telephone health coaching, and the program is slightly adapted depending on the group that they are delivering to. My Health for Life also runs workplace programs as well, so this is also free. So our team over at Stroke Foundation can run health checks either digitally or face-to-face, and then we will organise for a local health facilitator to come into that workplace environment and deliver the program to the staff. So I thought that it would be worth touching on some multi-agency collaboration. I think that My Health for Life is a fantastic example of the reach and the impact that an NGO-led preventive health program can actually have on the population. So each of our organisations, we bring a different experience, different expertise from each of our areas, and we do really pride ourselves on collaboration in the My Health for Life team. So we have a lot of partnerships with a number of other programs, with initiatives, with other organisations as well. So as well as My Health for Life, Health and Wellbeing Queensland fund a number of health programs. Some of them are the Healthy Tuck Shops, Deadly Choices, Life Education, the Queensland CWA Country Kitchens, Good Sports, Jamie's Ministry of Food, and we have standing relationships with them. So we work really closely with them so that they can support our program and we can support theirs as well. And we also work really closely with a number of other NGOs outside of the Healthier Queensland Alliance. Some of those are Arthritis Queensland. We work with the Alcohol and Other Drug Foundation, and we also work with Cancer Council as well. So this kind of collaboration so that we can really have the biggest reach possible is, I think, something that really makes My Health for Life quite unique. So this is a snapshot of our program outline. It's a bit difficult to see on the screen, and so I've got the PDF copies for you at each of your chairs. So you can see that the program is the 7 sessions across a 6-month period. So the program is run in the exact same way, regardless of the way in which it is delivered. The first session is always one-on-one between the eligible participant and their coach, and then sessions 2 through till 6 are all in groups if they do choose the group mode of delivery, and then session 7 is a check-in. The only difference is that if the person does choose the telephone health coaching option, is that every single session is done one-on-one, and therefore it's a little bit shorter. So the core content that the health coach delivers is exactly the same. What they do with that first one-on-one session is they work with the patient to develop a goal. And so that goal, we have a lot of people that talk about weight loss or physical activity or healthy eating as their main goal. But things like reducing stress, getting better sleep, reducing smoking, reducing alcohol, those are some other goals that they can develop. So they talk to their health coach about that first, and then the health coach will step them through each of the session based on whatever their goal is. So throughout this 6-month period, we do also give them some additional support. That's through regular contact via SMS or email. And then after the 6-month period, we have a 6-month maintenance program. So it is also digital resources that are sent out via SMS and email as well, just to touch base with the participants, see how they're going, and encourage them to go and speak with their health professionals or to do another risk assessment in case they are eligible for the program again. So our eligibility criteria, again, a bit difficult to see. I've also included a PDF on your chairs as well. So for the general population, it is above the age of 45, as long as the person doesn't have a diagnosis of type 1 or type 2 diabetes, heart disease, stroke, or chronic kidney disease. They then need to look at blood pressure, AUSD risk assessment or absolute CVD risk assessment to determine whether they're eligible. But I have pulled out the automatically eligible criteria as well, which is something that we like to focus on because our eligibility criteria is a little bit like a spider web, and it can get a bit complex. So if the person is above the age of 18 and they have any of these conditions on the left, then they are automatically eligible for the My Health for Life program as long as they don't have any of those diagnosed conditions. So we do have quite a comprehensive evaluation that was conducted by Griffith University, who are our external evaluation partner. In the interest of time, I've pulled out a single snapshot which outlines some of the key findings and program outcomes. And the evaluation was conducted from the beginning of the program, which was 2017, which is when our first groups were run, up until December 31, 2019. So I guess some key findings that we had were an increase in fruit and vegetable intake, and also a decrease in waist circumference as well. If you are interested in reading that comprehensive evaluation, please let me know, because we can distribute for you if you'd like to read some further information there. So what can My Health for Life do for your patients? So we talk about this program as an extension of the care that you are already providing to patients. So we are there as a complementary service. My Health for Life, number one, is free. It's a completely free program, and it doesn't require the participant to have a Medicare card or a Medicare number as well. So they just need to have a Queensland address. As long as they have that and they are eligible for the program, then they are able to, they're able to enrol. We also assess people when they come out of the program as well, or they can go through a self-referral pathway too, and if they are still eligible, they can re-enroll. So we do have a lot of cases where people will go through the telephone health coaching program just because they're not initially comfortable with doing a session in groups. They love the program so much, and then they repeat the program and go to a group session or a video conferencing session as well. So we have people that really develop that relationship with their health coach or their facilitator, and they really love that peer support, or they just love having that regular touch point with someone that they can talk about a specific issue with. So how do you refer your patient? So we accept referrals via medical objects or via fax. A patient can also go onto our website as well, which is myhealthforlife.com.au, and we have a risk assessment tool that's available on that website, a bit of a nice, pretty animated tool. It's based off AUSD risk assessment, and so that they can step through that themselves as well. So we have referral templates that have been developed for most medical software, and if you do use Best Practice or Medical Director, our referral template is already automatically available in those systems under the Supplied Template tab. It's either called My Health for Life or Referral-My Health for Life. So it should already be there for you, and it will pre-populate some of that demographic data as well in hopes to make things a little bit easier. So The PHNs being one of our alliance partners, they are a great source of information and resources as well. So you can ask your local primary care liaison officer to provide some additional support or information about the program, about local group sessions, or the availability of health coaches. And then the opportunities for referral, I think as Anna has mentioned in her presentation as well, we do recommend integrating something like a referral to My Health for Life into standard consultations, health assessments, or even the heart health check as well. So I just wanted to include some really fantastic numbers. So with our program, patients can self-refer. And because we have a number of teams that go out, they attend community events, we attend workplaces, we go to expos, we run the risk assessment screening tool with the general population. So we pick up a lot of people through community. So our numbers that actually come from primary care referral are really, really small. However, of those really small numbers, we find that 99% of people are eligible for the programs. They're identified through general practice typically, and they are mostly eligible for the program. And also 72% of those patients actually go on to enrol in the program. And that's in comparison to 35% of people who are picked up through community that then go on to complete. So it's over double, over twice. People are twice as likely to enrol if they actually are referred by a health professional. Even we had a look at if you would direct your patients to the My Health for Life website and they go through the risk assessment tool themselves, at the very end it will tell them whether they're eligible and it will ask for their contact details. But a large majority of people then click off that page and don't enter in their contact details, so our teams can't contact them. That's not the case when we receive a referral. So when you do send in a referral, it goes straight to our program support team, which sit within Diabetes Queensland in Milton. And they will call the patient and say, we have received a referral from your doctor or your nurse, and they have identified you as eligible for this program. And so I think that's a testament to the relationship that you have with your patient, and it also provides them with that little bit of a push and that little bit of a nudge to actually go through a program like this. So we, if you do use the PenCS clinical auditing suite of software, we have My Health for Life recipes that are available on the website. So these are for use with the CAT4 software. My Health for Life also has a top bar app as well that can identify which of your patient population is eligible for the program too, so you can make use of those tools. This is one of the Brisbane South, I didn't show on, looks similar. So Brisbane South PHN have also developed a quality improvement module that is My Health for Life specific. It includes the absolute CVD risk assessment, heart health checks as well. And so this can help you meet the requirements of the PIP-QI too, if this is something that you would like to integrate into your practice. And they're all available on the Brisbane South PHN website. We're also on health pathways, so we're under lifestyle modification programs, along with a number of other programs as well, Quitline, the coach program, Deadly Choices, things like that. Our eligibility criteria is on the page there, and also the referral pathway, obviously. There is a generic login too, so if you are familiar with health pathways, check out My Health for Life on there. And we have a lot of resources available, so the best place to get your hands on some of these resources are, number one, to speak to your primary care engagement officer from the PHN, or you can contact Heart Foundation or myself, and we can provide you with things like patient magazines, tear-off pads. We've got a lot of posters. We've got FAQ documents. We have pens. We have blood pressure breeding cards. We have a lot of different resources that you are able to house in your practice to give to patients, and also prompt them as well to ask the questions about a program like this. And lastly, that's my contact details. If you're interested in having My Health for Life come into the workplace, we have a specific workplace program contact email, but you are more than welcome to contact me directly at the Heart Foundation. I work in the primary care strategy space. So myself and the PHNs are here to support you with this program in your practice. So please feel free to reach out to us directly, and we can help you wherever we can. And that's me. Thank you. Well, we have time for some questions across everyone.
Any questions? Oh, sorry. Questions from anybody? Questions for Anna, Sam or Andrea before we finish tonight?
you. What is the premium risk out of 10 years in the Australian heart, 5 years?
Sorry, can you just repeat the question?
You know, the premium risk is for 10 years, your percentage cardiovascular, and the Australian one is out of 5 years. Why is there a difference?
The Framingham is 10 years. What were you referring to?
You know, like you've got 5% heart,
Oh, yes.
take risk, 10 years, it's 5 years. Why is there a difference?
I don't know. Good question. Can I get back to you?
With all the cardiovascular risk factors that you have at the start, there's like a lot more there than there is included in the absolute cardiovascular risk category. Is there one that's more accurate that includes those things like mental health and all that sort of stuff? Because I've got one of these that it seems that the absolute risk calculator misses off
Yeah.
a lot of things.
Yeah, good question. So yes, we do need to look at a broader range of risk factors, and I think with the new guidelines, we've got an expert group that are going to be working on that, drawing on some of the people who contributed to the original guidelines. And I agree, we need to look at including other risk factors in the guidelines, and I think that will happen going forwards, because you're right, we are limited in what we've now got in there for absolute risk. So all I can say is that with the new version of the guidelines, I think they will be looking at a larger number of risk factors. Yeah.
So I'll just add to that, because there is another, I'm just opening it here, there is another cardiovascular risk calculator. Sorry. It's a competition.
Is this Carissa's?
I think so, yeah, it's an American one, but I'm just looking at what it's called. I've got to find the paper. I'm doing it ultra rapidly. Okay, I might tell you on the side, because it's going to take me longer than I thought to find this. But anyway, it's not perfect, but it does include like about 10 to 15 different risk factors. And the other good thing about it is it includes things like what happens when you add aspirin or fish oil or things like that. So it can be quite good. It's in a... is that what it is? Q-Risk 3. Okay, cool. Thank you. Yeah, I'm just looking through this paper, but it's going to take me a while to go through this paper. So yes, Q-Risk 3. And there's another one as well. Oh, here it is. I found it. There's another one. Yeah, the atherosclerotic cardiovascular disease risk estimate, ASCVD. So there's those two. Okay. ASCVD, atherosclerotic cardiovascular disease risk estimate. It's another 10-year one. Why do they have 10-year, 5-year? My guess is just useful to have all that extra data. But yeah.
One of the things that I'm a nurse from the complex chronic disease team. We also run the cardiac rehab program at North Lakes. One of the things that we are really struggling with is the wait list time for patients attending cardiac rehab. And this is just a question for Heart Foundation. With the number of patients that are now being churned out from the acute sector, procedures are getting faster, patients are living longer, and we are expected in the community to do rehab still in the old-fashioned way, small gyms, and the number of referrals are just not meeting the demands that the acute, as well as what we're trying to do for the GPs, okay, to keep these patients out of hospital. There's a huge amount of money being spent on bowel cancer screening, breast screening. Should the Heart Foundation be spending money on people staying, providing free gyms for people, educations for people after they've had an acute attack or after they've had a cardiovascular event? Should that be the way to prevent, heart disease in the future? Us spending more money in that sector?
Not sure exactly what your question is, but I could talk around it and perhaps talk about, what it is that the Heart Foundation do around cardiac rehab as well. That might interest you. But I think you're exactly right in terms of, less time in hospital and more of a need for support for people who have been hospitalised or diagnosed or had an event. And yes, I agree with you, the waiting lists can be quite long. What we also do know is that a lot of people choose not to go to cardiac rehab as well, or, drop out of the programs. What the Heart Foundation does is we advocate for more cardiac rehab services. We certainly advocate for people to attend cardiac rehab, and we fully agree with, what you're suggesting is around it's a really important program for people. What's been really quite interesting, again, a benefit, I suppose, of COVID is that, well, not initially, but cardiac rehab programs, as you probably know, were closed down. Because again, face-to-face, group-based, exercise, it couldn't occur, and also some staff were redeployed. So what the Heart Foundation did in collaboration with our Queensland Government was we looked at supporting programs to provide telehealth. So one option, and programs, some of them have kept up the telehealth to support people. So it taps into, I suppose, if people can't go to a group-based program or don't want to, they could receive cardiac rehab via telehealth, but also it can extend the service so that there are more positions, or the service is more broadly available and has greater reach. So that's something that we've been advocating for going forwards as well, is that programs are able to continue to provide telehealth as a service. Is that something that your service does?
Yeah, we think we tried it, didn't we? During COVID we did try it.
Yeah.
But people still prefer the face-to-face.
And there's real benefits to face-to-face. Both Sam and I have talked about social support, and obviously, you would see that all the time, but also people needing supervised exercise. Post-surgery, we know that that's really important. So I think telehealth needs to be delivered selectively to the right people. But if they don't have anything else, telehealth certainly could be a service where they otherwise might not receive cardiac rehab at all. So I suppose the Heart Foundation is able to advocate. Our role is we don't provide the services, we don't have the funding to provide the services, but we certainly do advocate, and we do that all the time. And with the upcoming budget for our Queensland Government, we have done just that in highlighting the importance of our Queensland Government supporting cardiac rehab.
I love the sound of the My Health for Life program. Is there something similar for patients who, have been diagnosed with diabetes, that kind of thing? I mean, I've used the diabetes group session care plan referrals before, but also had a bit of trouble finding.
Yeah, we usually and this is in the instance also if we get someone that comes into the program that does have a diagnosed chronic disease as well. So we will redirect them to either the Coach program or the Get Healthy program. Get Healthy doesn't really have an eligibility criteria. I think you just have to be over the age of 16, I believe. And so we work really closely with those teams as well so that we can still provide some support to those people, just not with the My Health for Life program.
Sorry, you say Coach and what?
Coach and Get Healthy. Yeah.
Is there an online version of the My Health Life?
There's not an online version of the delivered program. So the program is delivered by a facilitator, but some of them do deliver it via video conferencing. So it's a small group, usually around 6 people that will take as a maximum within those VC groups. They will still attend every couple of weeks with their same group and same facilitator, and then they can be based anywhere around Queensland when they go into those particular groups. So there is a digital or there is an online method of delivery. Otherwise, there is telephone health coaching as well.
I would just like to clarify the billing of the 699. For example, I'm doing a care plan, and the reason for the care plan is like osteoporosis or musculoskeletal. And can I do the absolute or bill the 699 on the same day when I'm doing the care plan, or should I get them to come back? The thing in here is you can't bill it with health assessment, but yeah, I just don't know if
I'm going to have to get back to you about that, but does someone else have experience with that? Is there any other GP in the room that's able to give some advice around that? I think I'll have to get back to you because I'm not certain about that either. So can I, yeah, I'll get back to you afterwards.
Some last questions? No more? All answered? So there's a couple of things there that we will follow up for you and get those answers to those questions for you. But I think that might be it. So thank you very much, Anna, Andrea and Sam, for the session this evening, and thank you everybody for coming. And if you would like to see what other education we've got on, there's a brochure just on the front table if you want to take one of those on your way out, or have a look at the Brisbane South PHN website education calendar, and you'll see any upcoming education there. Thanks so much for coming this evening, and we'll see you next time. Bye.